And first of all, thank you for joining us today and welcome on today's webinar on ANCA-associated vasculitis. And it is organized by EMEUNET, Visibility and Global Affairs Subcommittee, and ERA-YNP. I'm Magda Osipyan from Yerevan, Armenia. I'm clinical rheumatologist. And it is my honor today to co-moderate it with Safak Miroglu. He's associate professor of nephrology at Istanbul University in Turkey. And he's a chair-elect of ERA-YNP and a board member of ERA Immunonephrology Working Group. Hello, Safak.
Hello. Thank you. It's a pleasure to be here.
First of all, let's go on some housekeeping rules because our webinar is going to be recorded. First of all, let me ask you to turn off your cameras and also turn off your microphones. It will be necessary for the recording. And second one, some rules about questions and answers. After the discussions, after the presentations of our speakers, we'll have a chat box where you can type your questions, and during the panel discussions we'll go on through this question, and also there will be ability to hit the raise your hand button and ask your questions directly to our speakers. So before the main topics about ANCA-associated vasculitis, let us a bit introduce you to our main organizing committees. First of all, let me introduce Christel Aud. She's a member of, she's a chair of Visibility and Global Affairs Subcommittee. And Christel is an assistant professor of rheumatology at St. George University of Beirut. And she is also a consultant rheumatologist at St. George Hospital University Medical Center in Lebanon. And today, Christel is going to present you about EMEUNET and about the main activities of EMEUNET. Christel, hello. The stage is yours.
So hello everyone, and thank you so much, Magda, for the introduction. So let me share my screen first. It means first so much to EMEUNET to have such a nice webinar, and really this opportunity to come together today and collaborate with nephrologists is really very nice. So who are we? So when I moved to Paris, I had the privilege of working under the mentorship of Professor Laure Gosseg, one of the 3 founders of EMEUNET. And she did not just teach me about rheumatology, but she also encouraged me to join the EMEUNET working group. And I will forever be grateful for that, because it really led me where I am right now, part of a very large network of passionate and driven rheumatologists who really share a common goal of growing in the rheumatology field. So you may be wondering who we are. So who exactly are we? We are the EMEUNET, the Emerging EULAR Network. It's a EULAR committee, a European network of young rheumatologists and researchers who are dedicated to growing and shaping the future of rheumatology. So it actually began 16 years ago with 3 rheumatologists, Daniel Aleta-Hamayabuk and Laure Gosseg, with a mission to widen collaboration, promote education among young rheumatologists and researchers in rheumatology, and eventually integrate them all into EULAR activity. So it was at the beginning more as a project, and then it actually grew into a huge network of rheumatologists. So we are actually today more than 3,400 members. And as you can see here, it has a structure with 6 different subcommittees. We have members of these subcommittees and leaders of subcommittees, and 1 EMEUNET chair and 1 chair-elect that coordinate all the different activities with the subcommittees. And so as you can see here, just let me up, yes. So as you can see here, all the work mainly is done by 63 subcommittee members who are at the core of EMEUNET. And then we have representatives in each EULAR country that we call country liaisons. So as you can see here, they do many activities during the year. And just to a bit show you the many activities that are done by EMEUNET, just a quick overview. We have different, so we have Tuwe and Diego, both the chair and the chair-elect of EMEUNET, and we have 6 subcommittees. So first, the education subcommittee, which is led by Pierre-Antoine, with different activities to promote scientific knowledge, educational opportunities, and even integrate EMEUNET member into the EULAR recommendation task force, and they also do podcasts. And we have the peer mentoring subcommittee with Alvise, who is actually the EMEUNET speaker today. And his subcommittee actually do so many nice activities, such as the mentor meeting at the EULAR and ACR Congress, or the peer review mentoring, which have been conducted for several years now. And we have the social media subcommittee, which is led by Siske and Latika, and they have been in charge of disseminating the word of EMEUNET through the different social media platforms, Facebook, Twitter, Instagram, and LinkedIn. And we have also the country liaison subcommittee that is led by Ertugrul with, as I have mentioned before, it's actually a vital link between EMEUNET and the country liaison at the national level. And they do very nice activities such as the Rheuma Vision this year, the contest, a new contest this year. And then there's the Visibility and Global Affair, which I am proudly leading, which organizes many activities such as these webinars. So in collaboration with different young societies, other specialty societies. We also do EMEUNET networking event at the EULAR Congress and many other activities. Then we have the newsletter subcommittee led by Anastasia, who provides monthly newsletters with the latest activities and projects done by EMEUNET. And it is released every month with different topics, such as the do not miss, the highlight of the Congress, the press review. So I will quickly have a bit an overview of the activities that we do. So we mainly encourage research and collaboration. We do social events. We collaborate with all these the nice young societies. We also promote training and education through different means, such as promoting the EULAR courses, webinar, podcasts, and regular newsletters. We also participate actively in the EULAR Congress with, as you can see, many activities. Our EMEUNET members are very active during the EULAR Congresses, and they host poster hall, they participate in ambassador programs. And we also have EMEUNET session during the EULAR Congress. As you can see here, every year we have a different session dedicated to EMEUNET. And we also have the mentor-mentee meetings that I've mentioned. And this year, the Rheuma Vision competition that will also be highlighted in a EULAR session this year. And we, of course, organized many webinars. So this year already, we had so many webinars with different societies, Young Grappa, the Asia Pacific rheumatologist, the PARE, so it's a patient association. We did a webinar with them. Again, the AYR and the Young Grappa, that was a EULAR endorsed webinar. And today we have our this nice webinar that we are doing with YNP. So EMEUNET, as you can see, it's not only a network, it's at the end like a family. And here we are all reunited at the General Assembly meeting at the EULAR Congress. And I'm sure that we will keep on growing and achieving many goals and recognition. So thank you very much for your attention. And I'm really looking forward to the presentation today on today's webinar. Thank you.
Thank you, Krista. Thank you for nice presentations. And I hope that after these presentations, we'll have more participants that would like to join the work of EMEUNET. And as I already mentioned, this webinar is organized in a collaboration with Young Nephrologist Platform. And please, Safak, can you introduce the mission, the projects, and what is ENP about?
I think my slide can be seen. I'm Shafak Miroğlu from Istanbul, Turkey, and I'm the chair-elect of the YNP. It's very nice to be
Shafak, can you hear us?
Yes, for now, can you hear me? I have a problem with my internet, so my connection got lost, but I'm back now. Can you hear me?
Yes.
Okay, good. Sorry about this unprecedented event. Okay, can you see my screen?
Yes.
Okay. It's a great pleasure to be with EMEUNET today. So let me briefly introduce and explain who YNP is, when it was established, and what the mission was at that time, how it is currently organized, what the main activities are at the moment, and how to participate in the activities of YNP. The European Renal Association has 5 official committees, and Young Nephrologist Platform is one of them. YNP is basically a network for all nephrologists who are 40 years of age or younger. It was established in 2013. Our logo was described at that time and was revised in 2018 and 2021. The mission was, at that time, to evaluate and understand the needs of young physicians and scientists in order to develop education, research, professional development, and leadership opportunities within the society, which are specifically tailored to the young nephrologist's needs. We are governed by the YNP board in its current organization. The YNP board is responsible for the management of all activities. It involves a maximum of 9 members, and all board members have to reside in different countries. The term is limited to 3 years, and Secretary General of the European Renal Association is our official advisor and our link to the ERA Council. As it can be seen, we have a very diverse board right now, and Paulina Pettinelli from the ERA headquarters is our committee coordinator and big help. What are our main initiatives? Well, I will not go into detail of these initiatives at the moment, but we have various national representatives all around the ERA geographic area in about 30 countries in Europe and countries surrounding Mediterranean. We have free ERA Congress membership program based on abstracts and published papers as original articles or reviews in the ERA journals. We are very active on social media. We have a separate X account, and we also have Instagram posts on the ERA main account. We collaborate with other societies, mainly the Japanese Society of Nephrology and the European Pediatric Society of Nephrology's young researcher group. And it's very nice to be here with the EMEUNET as well. We also have collaboration with DRA working groups on various projects, including research projects. We have an ongoing mentorship program for a couple of years now. Also, our members have been the co-authors of various chapters of the new ERA NAF manual, an online ebook. Also, we have a speakers database, which we use to select speakers for our main events and especially in the ERA Congress. Also, we have an ongoing collaboration with DRA journals, the Nephrology, Dialysis, Transplantation, and Clinical Kidney Journal. This collaboration mainly includes a YMP reviewer list, and an in-contest section with the Clinical Kidney Journal. And the papers for the section are being written by a young author, which is a YMP member and a senior author in the field. Participation is very easy for our activities. All ERA young members automatically become YMP members. Keeping track of monthly newsletters and delivered as emails and announcements on social media are very important. With these, our members can learn the new initiatives and open applications, then timely apply for them. Also, contacting the national representatives is a good option since they are closely in touch with us. Finally, it's possible to reach us on email and on our X account. YMP members constitute about 30% of all members of the ERA. As the end of 2024, we have over 7,000 members with the recent increase coming from the new National Society membership options. I want to thank to all YMP members and board members for their contributions throughout the years. Thank you.
Thank you. Thank you for the fantastic presentation. And now let's dive into our first presentation, already connected with ANCA-associated vasculitis. And our first topic is a practical approach to renal involvement in ANCA-associated vasculitis. And let me introduce our first speaker, who is Lauren Floyd. Hello, Lauren. Lauren is a specialty training doctor in renal medicine. She's based in Greater Manchester in UK, and she's doing her PhD at the University of Manchester, and mainly focusing on ANCA-associated vasculitis. And in addition to her research interests, she is also involved in different groups connected with vasculitis, and she is also a board member of European Renal Association Young Nephrologist Platform. So Lauren, hello, the floor is yours.
Thank you for the kind introduction. I'll just share my slides. Can you see my screen? Wonderful. So yeah, thank you so much for the kind introduction. My name's Lauren. I'm a renal trainee in Greater Manchester in the UK, and I'm one of the YMP board members. And it's a real pleasure to be speaking to you today on this as part of this sort of wonderful webinar that you've put on, and it's great to have the collaboration between the two societies. So I'm just going to talk really about a practical approach to renal involvement within the context of ANCA-associated vasculitis. There's quite a lot to cover, so I've tried to touch on some of the key bits and some take-home messages. I don't have any disclosures of interest for the purpose of this talk. So we'll over the next 15 minutes or so, I'll try and talk about sort of the significance of renal involvement within the context of ANCA-associated vasculitis, why it's important, and some of the prognostic factors, the role of the kidney biopsy, how to monitor kidney function in those with vasculitis, how to diagnose a renal flare, the role of a repeated biopsy, and then, like I say, just some summary take-home points as well. So I guess that the main thing to start off with is that kidney involvement within the context of ANCA-associated vasculitis is really common and is important to recognise. The frequency and severity of kidney involvement really varies according to sort of the clinical phenotype and ANCA serology, so the difference between ANCA positive and negative patients, and like I say, the phenotype. The main classical presentation is sort of a subnephrotic range proteinuria. It's very rare that vasculitis patients will present with heavy proteinuria or nephrotic syndrome. It tends to be much a lower amount, so subnephrotic range. They can present with microscopic hematuria and a decline in kidney function. And this can be very progressive and very rapid. And we often refer to it as a rapidly progressive glomerulonephritis, so this RPGM picture that we see. And these graphs are taken from an old study, but really demonstrate the point that the prevalence of renal involvement within vasculitis can vary depending on the clinical phenotype. So renal vasculitis is seen within the majority of patients with MPA, for example. So about 90 to 100% of patients will have renal involvement. GPA tends to be between sort of 50 and 80%, and then EGPA has less renal involvement but can still occur. Now, why do we worry about it? Well, I guess the main thing to say is if you've got kidney involvement with your ANCA-associated vasculitis, then your outcomes are very poor, both in terms of renal survival and overall mortality. And left untreated, the prognosis of survival at 1 year in patients with renal involvement is very poor indeed. Now, this is quite a busy slide, but the two graphs on the left of your screen are taken from a UK study back in 2002 that looked at 5-year outcomes of patients with renal vasculitis. So included about 246 patients who all had renal involvement. And what the graph on the left shows really is that the worse the creatinine at presentation resulted in worse overall survival, and the 1-year survival in these patients was 82%. The second graph shows that actually when you've got end-stage kidney disease, your overall survival is also very poor. And in the 30-odd% that had end-stage kidney disease, nearly half of those had died at 5 years. So renal involvement is really associated with poor mortality data. The second graph on your right is from a study that looked at over 500 patients that were been recruited to 4 RCTs, and they looked at trying to determine long-term patient survival and prognostic factors from the point of presentation. And they identified 5, but again, eGFR of less than 15 came out strongly as a poor prognostic factor. In terms of predictors of renal survival, well, again, many of them are the same. So serum creatinine and lower eGFR at presentation result in a poor, sort of the worsening renal survival. If you require dialysis at presentation, again, that's a poor prognostic factor. Older age and race and ethnicity, so African-American patients, whilst it's less common, they tend to have poor outcomes compared to Caucasian populations. And histopathological factors, which I'll come on to talk about, again, associated with worsening outcomes. So the less percentage of normal glomeruli, the worse of the IFTA and sclerosis. But it's important to remember that despite these numbers, patients can regain kidney function with treatment. Patients on dialysis can become dialysis independent. And it's really important that even in the context of renal impairment, we try and preserve as much kidney function as possible to prevent people going on to dialysis. So what about the role of the kidney biopsy then? Well, it's the gold standard for diagnosing glomerular kidney disease. You tend to get this sort of pathological hallmark, which is the necrotizing crescentic GN without significant immune complex deposition, which we term sort of porcine-immune. And that, like I say, that's the gold standard. But there is a debate as to whether or not a biopsy is always necessary. Some clinicians would argue that actually if you had patients with a very strongly positive MPO or PR3 with clinical features of a vasculitis and a low clinical suspicion for, say, maybe secondary vasculitis cause or mimics, then is a biopsy necessary because it's not a risk-free procedure. That being said, the role of the biopsy in terms of prognostication and aid in prediction of renal recovery is really important and can't be dismissed. And there are mimics for renal vasculitis, and I'll come on to talk a little bit more about the prognostication in a second. But this is what the KDIGO guidelines recommend, and they essentially say that kidney biopsy should always be considered in patients suspected of having acute kidney involvement with if you're querying vasculitis. So it doesn't need to delay treatment, but it should be considered at some point. And really the purpose of a renal biopsy is it helps us with these things. So these are the two main risk prediction tools we have for determining end-stage kidney disease and renal survival. So the top one is the burdens classification, and this looks at the percentage of abnormal and normal glomeruli. And as you can see, those who have over 50% sclerotic glomeruli have very poor renal outcomes at 10 years, whereas those in focal class who have over 50% normal glomeruli have much better outcomes. And similarly with this is the bottom table and graph is the renal is the ANCA renal risk score developed by Silka Brooks and has recently been revised. And this again used the percentage of normal glomeruli in addition to other parameters like serum creatinine, the degree of interstitial fibrosis and tubular atrophy, and it determined a risk score. And again, as you can see, those at very high risk had much worse kidney survival at 10 and 12 years than those who had a low risk score. But again, to reiterate, these are not a decision aid to determine treatment. Patients included in these prognostic tools and how they were developed were all treated. And a lot of these patients included were from a time where we didn't have some of the treatments we have now, things like avacopan, the option of using more combination treatments. So again, it has to be interpreted within the context of what we know and what we have access to now. So in terms of monitoring kidney function, so kidney function and urine dip should be done at every clinic visit, and I think this is across all clinics. Urine dips are really an underutilized tool and give so much information. And if you prepare patients and you send them away with POTS, most of them will come in prepared to provide urine to be dipped at their clinics. Patients with renal impairment and CKD should be treated per the guidelines, so they should be on renoprotective agents, RAS inhibition, SGLT2s, MRAs. And it's important to keep an open mind that actually there's lots of reasons why patients with vasculitis can have renal decline. Some of this can just be progressive scouring from the initial damage. Hypertension, hyperfiltration, obviously repeated renal relapses can contribute, but things like nephrotoxic medications, infections, especially within the first year when their immunosuppressive burden may be high, and other causes should all be considered and not overlooked. So what about monitoring kidney function? Well, as I said, persistent proteinuria, whilst it's a sign of renal involvement, can also be a sign of scarring and can persist and be present even in the absence of disease activity, but it is a poor prognostic sign. And that's true not just in vasculitis, but other renal pathologies as well. This is a post hoc analysis of patients included in 5 European RCTs. So I think it included just over 570 patients. And what they found was that persistent proteinuria after induction therapy was associated with increased risk of death, end-stage kidney disease, and relapse. And persistent hematuria as well was an independent predictor of relapse. So these parameters can't be overlooked. And I guess this is part of the challenge in diagnosing a renal flare. So clinical indicators, as I've mentioned, worsening renal function, new, persistent, increasing hematoproteinuria, all signs that make you think about a renal flare. ANCA titers, we know ANCA is not a perfect biomarker, but in some patients can correlate with disease activity. Scoring systems such as BVAS can be useful. And then, like I mentioned earlier, just keeping in mind other potential causes for renal decline. So maybe getting imaging to assess to make sure that there's no other causes that need to be considered. But it is a challenge, and the biomarkers that we have in terms of creatinine, proteinuria, and hematuria are really limited. And a rise in serum creatinine tends to be a late indicator of kidney impairment. So by the time you've noticed the creatinine's climbing, there's probably already established active disease. Proteinuria in particular, as I mentioned, can be a sign of scarring and can persist even in the absence of disease. So again, a very limited biomarker. That being said, this is a nice graph that was done as part of a retrospective study looking at nadir, creatinine, UPCR, and hematuria in renal recovery. And what they showed was that all three parameters can occur occur later than other signs of clinical remission. So actually it took over a year for hematuria and proteinuria to settle. Creatinine tends to settle a bit quicker, but it does suggest that ongoing renal recovery can continue for a significant time after diagnosis. And this is what makes it challenging, because it's hard to know whether what you're seeing is sort of slow renal recovery, whether this is all scarring, or whether this is relapse, and you don't want to miss that. So looking to the future and things that may help us, well, there's a few things that are coming that have been presented and published, all of which really need larger validation, but we do need a better biomarker. So urinary lymphocytes have, there's been a small study in 100 patients looking at the urinary CD4 T cells as a predictor of renal relapse. And that had a good diagnostic accuracy that exceeded that of ANCA titers, proteinuria and hematuria. Similarly, urinary soluble CD163 had a high precision for separating renal vasculitis flares from other flare mimics. So there's definitely things that offer potential on the horizon, but all of these need validation. So I guess that leads us to the role of the repeated renal biopsy then, and how that can help us. And it can be done for several reasons. So the biopsies can be done for cause, there's suspicion of disease recurrence, whether there's an unclear cause for renal deterioration, or if someone's just got persistent or worsening hematoproteinuria. Some studies now are protocolizing repeat biopsies, and some do interval biopsies just to assess therapy and ongoing management. So this was one of the first in main studies looking at 59 interval biopsies. So they basically did 59 biopsies to assess the response to induction therapy. And what they did was they asked clinicians to determine whether they thought patients had active or inactive disease at the point of the repeated biopsy. And what you can see from the blue bar graph at the top really was that in patients who they thought had active disease, actually only 42% of the cases were active. The others were inactive or had other pathology. In those that they thought had inactive disease, they were actually pretty accurate determining that. So 97% of the cases they thought were inactive they were correct. So we're very good at saying there's no disease, and less good at predicting when there is disease. But interestingly, they then looked at how this changed immunosuppression. And again, those that they thought had active disease that maybe didn't, 56% of patients had a reduction in their immunosuppression. And the same with those with inactive disease. So once they had that confirmation, immunosuppression was reduced. And overall, the change in immunosuppression was 75%, which is a huge amount, really, if you think about changing the management of those patients based on the biopsy. Importantly, there were no major complications from the biopsies in that cohort. This was a similar study, slightly less patients. This was from the Johns Hopkins group in the US, and they looked at repeat for cause biopsies. So 29 patients had second biopsies. And again, they showed a relatively similar amount of active disease. So 38% had active disease, although the change in immunosuppression in this group was slightly less, but still significant at 45%. The main indication for repeated biopsy in this group was elevation in serum creatinine. But one of the interesting findings from this group was that actually active GN present on the second biopsy was present in 70% of patients that had new onset hematuria and/or another parameter, and was present in 20% of patients with persistent hematuria. So hematuria or new hematuria may have some significance. So I guess as a bit of a summary, I just really liked this image. It's from Dr. Adler when he was working at Cambridge, looking at sort of how we define renal response in ANCA vasculitis. And I guess the take home from this talk really is that there's lots of surrogate markers for renal injury, and the kidney has a lot of potential different endpoints, and is challenging, especially in the context of very limited biomarkers. But I guess the future is bright in terms of other things that may change that longer term. So as a summary, it's been a bit of a whistle-stop tour. I've run over slightly, but I think the main take-homes really kidney involvement is a severe manifestation of ANCA-associated vasculitis. It should be taken seriously, and close follow-up is needed. Hematoproteinuria can reflect kidney involvement, but is not always a sign of disease relapse. And the repeated biopsy can be very valuable in some cases. I think regular monitoring and management of CKD in these patients is really important. And overall, all of these things really are to sort of aid us in terms of tailoring treatment based on disease activity and personalized care. Thank you very much for listening.
Well, thank you, Lauren, for the great presentation. And it's a pleasure to present Dr. Alvise Berti to perform his talk on management and treatment of ANCA-associated vasculitis. Dr. Berti is an assistant professor in rheumatology. He has been a member of EULAR and EMEUNET since 2015. After his specialization in rheumatology, he has spent 2 years at the Mayo Clinic in Rochester, Minnesota, in the United States. And he is currently working in the rheumatology unit of St. Chiara Hospital and Center for Medical Sciences, University of Trento in Italy. Dr. Berti, please.
Thank you very much for this kind presentation. Can you see my slide in presentation mode?
Yeah, looks great.
Good. So again, I'd like to start by thanking for the kind invitation. And I don't have anything to disclose in particular. And this is how I structure my presentation. So as you know, ANCA-associated vasculitis is a group of multisystemic rare autoimmune diseases encompassing rheumatosis with polyangiitis and microscopic polyangiitis. For the purpose of this presentation, I want to speak about the third class of ANCA-associated vasculitis, EGPA, eosinophilic granulomatosis with polyangiitis, for brevity, essentially for time reason. As you know, there are a lot of overlapping manifestation among these two forms, and 70 to 90% are ANCA positive. Just wanted to point out before to start and go in depth of my presentation that there are three main non-independent risk factors for relapse, which is a diagnosis of GPA, a PR3 positive, ANCA positive serology, and to be a relapser. These three factors condition the prognosis of the patient. So it means that a patient that has these three factors tend to have a higher relapse risk as compared to the other patients, whereas a patient with a diagnosis of MPA, MPO ANCA positivity, and newly diagnosed patients are tend usually to have a more severe disease. Obviously, this is a tendency. It's not valid for all the patients. This kind of stratifications, it's important to keep in mind when we assess the patient at the beginning in order to balance the type of treatment and of management that we do. And along on the same line, it's already have been shown in the last 15 years that there are difference in between the type of manifestation in PR3 ANCA positive and in PR3 ANCA negative patient more than in the disease subset GPA and PA, meaning that the patient that are PR3 ANCA positive, the patient that have PR3 ANCA positivity could have are often associated to those more granulomatous manifestation, such as chronic sinusitis or lung nodules, and as opposed to the patients that are MPO ANCA positive that are more strictly associated with those classical vasculitis manifestation as renal vasculitis. And there is obviously an overlap of the manifestation, which is in part, at least in part, linked to the different ANCA positivity. This is the view of the last 15 years. What I want you to show in my presentation is that this landscape is changing now, and more articles are accumulating, trying to stratify the patients in different ways, in more classes, which is not just dichotomic, NPO ANCA positive and NPO ANCA negative, or GPA versus NPA, but there are different kind of subset of disease associated with different prognosis. With, as you can see from the color code, are actually reported in my slide, with the patient with the high creatinine and CRP having usually the worst prognosis as compared to other patients that have ENT involvement or that are PR3 ANCA positive with inflammatory multisystem disease that usually carry a better prognosis. Finally, as you know, in 2022, new ICR EULAR classification criteria have been proposed. Also, these criteria are classification criteria, so it means that these are not for diagnosis, but these are useful to classify the disease. As you can see, we moved from classical criteria based on the presence or on the absence of several features. We moved to new criteria, which are score criteria. And I want you to highlight that now the weight of the ANCA specificity is very high as compared to for the diagnosis with PR3 positivity, that it's by itself, that it is 5 points by itself, and NPO ANCA positivity 6 points for a diagnosis of GPA and NPA respectively. So how do you manage the patient with ANCA-associated vasculitis? Obviously, with a structured clinical assessment, and even though there is guidelines for management and treatment of the vasculitis, at least the EULAR guideline does not cover in depth how we should treat the patients. EULAR guidelines are much more focused on the treatment rather than on the management of the patient. And so one of the main issue of the disease is what we should do in a patient with ANCA-associated vasculitis, what we should do in all the patients, and what we should do only in subset of patients. So this is a review actually of an international group. And you can see that there are a core set of tests that are suggested to be implemented in all the patients with a suspected ANCA-associated vasculitis, whereas there are second-level tests that needs to be considered only in those patients that have a positive first-level test. So it means that, in other words, that you need to do some laboratory exam assessing for inflammation with CRP, blood test, creatinine, and so on in all the patients. You need to do an EKG and transthoracic ultrasound in all the patients. You need a chest imaging in all the patients. You need to assess the kidney in all the patients, but then only in those patients that have positive test or a clinical sign suggesting a positivity in a specific organ needs to go on the second level test. A classical example could be the peripheral neuropathy, that if a patient have some clinical symptoms suggestive of clinical neuropathy, then an electromyography is suggested. Otherwise, it doesn't need to be done as a first-line therapy, as a first-line diagnostic test. Just a few words on the biopsy, the role of biopsy. I used to think at least, that when you do a biopsy to confirm the diagnosis, as this is a suggestion from the main recommendation, you are okay with that. But it's not so simple. In fact, only the kidney have a diagnostic yield of biopsy, which is quite high. As you can see here, from 85% to 91% from the main publication on the top. And it's impressive to see that one of the organs that we use to biopsy, which is actually ENT, sinusitis is often biopsy, show the presence of vasculitis in 25% approximately of cases, no more. Or even worse, the lung, in which a transbronchial biopsy have a diagnostic yield of up to 12%. So up to 12% of the transbronchial lung biopsy show vasculitis and no more. So, and really we need to be careful about the interpretation of the biopsy, because sometimes it could be non-diagnostic and you need a good pathologist to have the right interpretation of the biopsy that we do on the patients. After you assess the patient, you do all the tests, eventually you do a biopsy. If you can do that, not in all the cases we need the biopsy. Then obviously there is the re-stratification. Re-stratification, as is suggested by all the guidelines, not just from the EULAR one, suggesting the stratification based on the severe versus non-severe disease, or as the EULAR guidelines suggest, organ life-threatening disease versus non-organ life-threatening manifestation. So this is important because this helps us to balance the level of immunosuppression of the patients and how strict we need to do with the follow-up with the follow-up visit of the patients. So to sum up this second part of my presentation, we need to do to the patients several clinical history and evaluation, several lab tests, to do some imaging tests to assess the disease severity, and collaterally, we also have to collect all those information about comorbidities, so important to collect them at baseline. Eventually, we can discuss about that later to understand if there is chronicity on the biopsy, on the renal biopsy. If we do a renal biopsy, to try to understand about the fertility of the patient. This could help us in choose the right treatment, quality of life, and so on. But then we induce our patient with the treatment, and then we decided the follow-up. Follow-up requires for sure some clinical history and evaluation, along with some laboratory tests. But the real issue is that no guidelines really tells you how often you have to see a patient. Obviously, it's recommended to see the patient quite often at the beginning, in the first weeks of after induction of remission, or during the induction of remission, depending on the regimen that you choose. But then it's not really, there is no clear suggestion about how often you have to see a patient. And personally, it's one of the things that it's one of the main issue, I guess, of the follow-up of the patient, to understand the right follow-up, the right timing for every patient. So I suggested to do it every month when the patient is stable, but then at the beginning of the disease, there is no real interest. There is no real time that could be suggested, but it may depend a little bit from the treatment that you choose, as I will tell you in a second. And finally, how do we assess remission? Obviously, from a clinical standpoint, it's the absence of the disease, and accordingly to with a low dose of glucocorticoid. That's what most of the centers do, but there is no a single definition, as you can see from this review from the literature by Monti et al., that put together the different definition of remission using the different trial along the years. What is interesting, I'm not going to speak about that because there are no literature out there, but during the next months, the ACR EULAR response criteria should be published, helping us to have a unique and comprehensive definition of remission that can be used in all the centers, as compared to the heterogeneous definition of remission that has been used in the trial so far. Finally, I go to the last part of my presentation, which is about the treatment. What does the guideline say about the treatment? There are several, first of all, set of guidelines. You can see the ACR, EULAR, the one that I'm referring to for most of my presentation, and the recent KDIGO guidelines. All of them have several points in common and a few differences. Just wanted to, probably everybody knows what the guideline says. There is an induction of remission and then a remission maintenance. The induction of remission puts on the same plate, on the same level, the use of glucocorticoid plus rituximab or glucocorticoid plus cyclophosphamide for severe disease, while at least for the EULAR guidelines, rituximab and or mycophenolate or methotrexate should be preferred for the non-severe disease. And after a few months of this treatment, then there is a remission maintenance, which is actually that could be based on rituximab or azathioprine or other treatment that should help to reduce and potentially suspend glucocorticoid That has to be done for at least 2 to 4 years. Along with this line, there is also the role of avacopan that is taking place, and I will speak about that in a second. So since obviously the presentation is limited, I decided to focus on 3 main points, which is really close to the bottom of my heart, since it's really something that is actually not very well defined in all the sets of guidelines. One is, what about the dose and the timing of rituximab, and how long should we go for rituximab? There are evidence that rituximab 500 milligram every 6 months for maintenance, right? It's actually the preferred dose, and this is what the guidelines suggest as suggesting as a potential first line, but it's not the only treatment we have. We also have the 500 milligram on demand that could be done in some patient, and then the rituximab of 1 gram every 4 months as for the Retardrem trial. So is one treatment better than the other? There are more evidence on the 500 milligram every 6 months, but on the other hand, I think that the main message should be that we should choose the best dose in every patient. For instance, the regimen on demand could be chosen in those patients that are particularly old, or maybe that have low immunoglobulins. On the other hand, the use of rituximab 1 gram every 4 months could be used in those patients that have a more severe granulomatous disease, a relapsing disease like chronic sinusitis or retroorbital masses, for instance. How long should we go for rituximab? Well, that's another open question. Guidelines says at least 2 years, at least EULAR guidelines, between 2 and 4 years, but there are evidence saying that on paper that potentially we could go on lifelong, depending on the patient. So we should tailor the treatment to the patients. Obviously, avacopan is actually taking place more and more. The trial that you surely have read, this is not so recent, show that there is a non-inferiority for the induction of remission with avacopan, and even a superiority of avacopan as compared to prednisone plus standard of care for the long-term maintenance, showing that avacopan could really it's really helpful in keeping the patient in remission, and also evidence in improving renal function on the long run. Third point that I wanted to touch before to finish is the glucocorticoid dose. All the guidelines agreed about the use of a reduced dose of glucocorticoid based on the results of this clinical trial, which is the PEXIVAS trial, showing that there are using less glucocorticoids is equally effective to the standard dose, and leading to less severe infection in the first 12 months after diagnosis. But recently, real-life data from the French group show that these data are not confirmed, and the patients in the rituximab-treated patient who received glucocorticoid, reduced dose of glucocorticoids, were more likely to experience death or ESKD and to achieve the primary outcome without having less severe infections. So this kind of it's a little bit in contradiction with what the trial says. The results then of the TAPIR trial show that indeed the patient that for the maintenance of remission don't withdraw the glucocorticoid as shown here by the red line, as compared to those that continue the glucocorticoid 5 milligram during the first 6 months of maintenance of remission, as shown here by the blue line, usually have a higher risk of relapse. But it's important to highlight, as this effect is really on the group that doesn't use rituximab, but on the group that use other type of conventional immunosuppressive drugs. And these are only minor relapse, leading to further interpretation of these results. So to conclude, I just want to highlight that there are several topics that are not covered by the guidelines. One is something that Dr. Floyd already talked about, is about the possibility, the role of kidney biopsy for predicting the renal outcome. I'm not going to speak about that. She already mentioned some of these studies. The point is that these are not implemented in the guidelines, and the level of chronicity or the percentage of the normal glomeruli is not really helping yet to balance the level of immunosuppression or the follow-up for the patient. This is more for research, unfortunately, as compared to the information that the renal biopsy could give for the prognosis. And the other topic that is not really covered by any of the guidelines is the role of ILD, the interstitial lung disease. As you know, this is really affecting the prognosis. There is plenty of literature about that coming from both the pneumological world and from the rheumatological world, saying that among the patients with the UIP pattern ILD, only those with ANCA could develop the vasculitis. And among the patients with vasculitis that are MPO-ANCA positive, only those MPO-ANCA positive will develop a UIP pattern ILD and will have a worse clinical prognosis. There is a clinical reason because of the association between MPO-ANCA and UIP, and this is linked to the MUC gene variant, which is only associated with the MPO-ANCA. So there is a genetic background linked to that. And there is in essence, the big issue is how do we manage these patients? Do we need to follow up them? How do we need to follow up, since the prognosis is essentially linked to the UIP pattern of these patients and not really about the systemic disease? Should we use antifibrotic therapy or not? There are obviously opinion articles, and here is an example from Mayo Clinic, but there are no actually indication in the guidelines about how to manage these patients. So in conclusion, I touch on these topics: symptoms and diagnosis. How do we need to follow the patient? We should do a structured clinical assessment. There are indications by guidelines and recommendations about how to treat and how to manage this patient. And I focus specifically on rituximab, avacopan, and glucocorticoids. But then there are several topics that are still not covered by guidelines and recommendations. And with that, I thank you for your attention and again for being here.